Well, I am sitting here with my longtime online friend, Stephanie Meredith. And I will say that someday I hope we will meet in person. I don't think we've done that over the course of the past, couple of decades. But for now, I will just say welcome to my screen.
Oh, well, and thanks so much for having me.
um, well, Stephanie, I think you know that the immediate reason I asked you to be here today is because you authored a study along with a few other people about prenatal diagnoses of Down syndrome. And I do want to talk about that study. But before we get there, I would just love to introduce you to our listeners in more general terms. So I was wondering if you could just tell us a little bit about yourself and about your family.
Sure. So I am the mom of three kids, and my husband and I have been married, gosh, 27 years now. It's been a while. And
Congratulations.
thanks. And my oldest son was born with Down syndrome. He's 23 years old. And then I have 21 and 16-year-old, almost 17-year-old daughters.
Mm.
And I was 23 years old actually when I had my son with Down syndrome. I had a postnatal diagnosis about 4 hours after he was born. Our doctor was pretty matter of fact about it. He came in and he said, he's got this and this and this symptoms of Down syndrome. And our hospital, though, actually the next day had this pretty progressive program at the time
Mm.
where they had parent support staff who came in almost immediately, after the child was born.
Huh.
He was born on a Super Bowl Sunday, so they weren't there the day he was born, but they came in the next day. And they provided us at the time the book Babies with Down Syndrome. And this
Mm.
mom had a child with Down syndrome and showed us a picture of her son on a bike. And for us, that
Wow.
was just such a normalizing moment to realize life could still be fun. And I think that was such a great program at the time. They actually had three women on staff at the hospital who did that. One had a child with Down syndrome, one had a child with hearing loss, and one had a child with cleft
Mm.
lip and palate. And they all served families whose kids were in the NICU. So that was
It's
my
amazing.
first introduction
Yeah.
to motherhood.
Wow, gosh, there are like so many questions I want to ask you just from that. Let's get back to that moment because I do want to ask you more about it. Could you also just give us a little bit of a where I think particularly for Andy, who is your oldest and is now you said 23, right? So he's the age you were when
Yes.
you had him. So what does his life look like now?
So he's actually got a very busy life at this point. He is auditing a couple of classes at our local college. Um, and he's specifically auditing classes in photography and web
Mm.
design and business. And he's an intro to business right now. And that's
Wow.
because he also has a photography business. He's a very talented photographer. And I always
Mm.
think it's really important to tell people that, he's got this really amazing talent and he still struggles with
Mm.
with academics. Those are, if Andy were born without Down syndrome, he would be the jock, and it would not be academics would not be the thing that excites him the most.
Yeah.
And
Yeah.
so
Yeah.
he is also a lacrosse coach at the
Hmm.
local high school, and he's an assistant coach, and he works at our local Publix grocery store where he got the job himself.
Well, I love hearing about Andy, and I've loved over the years just because you are a mom who has a child 6 years older than our daughter Penny. You have been one of the people who I have really appreciated, in terms of sharing on Facebook and obviously being able to ask questions, but also just watching your life and being able to ask not just ask questions, but kind of envision. And it's so funny because Penny and Andy are very different. Like she is the last person you who would ever want to like coach lacrosse, for example. She actually loves books and reading, and I think it's important for us, to note just the diversity among our two kids, much less among the population of people with Down syndrome in general. And yet, it's also just really fun, as you said, to be able to kind of envision what's ahead in life with a disability and
Mhm.
not seeing that as simply a pronouncement of what can't happen. That there are all sorts of possibilities, even though they will be pretty specific to the kid and the family, and over time, the adult who is who's there. So anyway, thank you for being that person along the way. Um, Another topic that you have been a go-to on for me, though, is in this whole realm of prenatal testing, prenatal diagnoses, and just really being a gentle but very knowledgeable and kind voice in the midst of a lot of both confusion and energy, and around those topics in our culture. So I wanted to start just by asking you, like, how did this become your professional life? Like, how did you become the person that I would be saying, can you come on a podcast with me and talk to me about prenatal diagnoses?
Sure. Yeah. I think for me, I actually, because I had such a great diagnosis experience, I kind of
Yeah.
just assumed that that's how it was for everybody else. And so when Dr. Scott Coe's research came out in 2005, and it was uncovered that a lot of families were not having very positive experiences, I realized that I really wanted everyone else to have that kind of support and
Mm,
information and guidance that I had. And I think too, I had gotten involved probably after Andy was about 1 years, about one, um, with getting information to Russia for babies who were institutionalized, and trying to empower parents there with more accurate, up to date information about
mhm,
outcomes, so that they could make more informed decisions about raising their kids. And
mhm,
so when that research came out from Dr. Scott Coe, my husband and I, he's a designer. I was a technical writer at the time,
mm,
and we thought, gosh, could we put together a resource that clinicians will feel comfortable handing out prenatally? Because we knew that they were going to be very protective of those patients. And so we knew that everything handed out to them would need to be very research based as far as all the psychosocial claims that we would make about Down syndrome. And so
yeah.
we thought, well, could we put something together that they would feel comfortable giving to their very vulnerable clients in that moment?
So yeah, before I ask you specifically about that resource, which I want to do, can we back up a little bit and just talk about the history of prenatal testing and screening? So there's, prenatal screening has changed even over the course of, our lifetime for sure. And I'd love to hear you speak to that a little bit, but then also talk about, like, what is the purpose of it? Who gets it? How has it changed? Like, whatever kind of overview information you think someone would need to know to understand the significance and importance of the resource that we're going to talk about. Can you just give us a little bit of that big picture?
Yeah, absolutely. So you've got screening technology, which basically takes the blood sample from from a pregnant woman and says um, maybe what the chances might be that she is going to have a baby with, any number of different genetic
Yeah.
conditions.
Yeah.
And that test can be more or less accurate depending on the condition. And that was also in the news the last
Yes.
year.
Yeah.
And
The New York
so
Times did a report on that, I think, that was pretty shocking, right? As far as just women really not understanding what the meaning of these tests were, right?
yeah, absolutely. And I actually have a family member who was pregnant at the time that found out that her baby had increased chances for Turner syndrome.
Mm,
And when she got those results, she came to me because she knows what I work on. But in her experience, the her clinician did not end up letting her know that it was chances and what the positive predictive value for the test was. And so, and when I say positive predictive value, that's a concept that's really hard, took me a number of years to wrap my head around.
I
But
am
it's
still
basically,
wrapping my head around it. Totally.
yeah, yeah, because when people tell you that a test is 99% sensitive, it means that it picks up that condition in 99% of the population, but it doesn't mean that it's necessarily 99% accurate for you. And so
Hmm.
they have to weigh a lot of different factors to figure out whether it's accurate for you.
Mm,
So for example, your age can make it less, if you're younger, it can make it less likely that it's accurate for you.
mm,
And so in her case, there is a positive predictive calculator on the internet that you're able to access. And we plugged in her numbers. And when we
huh,
actually looked at it, her chances were only like 23% that it was
huh,
accurate for her.
right.
And then I also gave her information about Turner syndrome. And she was like, well, that seems like something that in our family we could manage. And so, but she hadn't been given all of that information to really
Right.
understand both what the test meant and what the condition was. And
Mm,
so there's that screening component. And when Andy was born, that screening was much less accurate than it is now.
right.
Um, but it's still not 100% for any of those screening tests. In order to know with almost 100% certainty, you would need to get an amniocentesis or a CVS, which are considered diagnostic testing. And so
So can
those
I
are the
just interrupt you for 1 second? Like with
Sure.
the person who came to you with the potential diagnosis of Turner syndrome, if she had not talked to you, would she have thought there was a 99% chance she was having a baby with Turner syndrome?
Oh, she thought it was pretty certain when she got it, and her
Right.
baby
Okay.
did
So
not
she
have
thought it
Turner
was
syndrome.
okay. So she thought it was certain, came and talked to you. You did the calculations. It's 23%, which is still significant, right? Like it's not nothing, but it's very different than 99%. And then she went on to have a baby who did not have Turner syndrome.
Right.
Yeah, okay. I mean, that's just such a like a one I mean, wonderful in the sense of like clear example of why these tests can be misleading. And then to your other point that once you gave her information about Turner syndrome, she was like, "Oh, okay, like we could handle that. Like either way, I can carry forward in a different way than I might have with the information I was originally given." So anyway, thank you for that example. I'll let you keep talking now.
Yeah, no, I think that, we've seen over the years now that there's been a huge uptake in the new cell-free DNA test. And that was released, around 2011, 2012 is when it really
Mhm.
exploded onto the scene. And that is the more accurate blood test that a lot of people are utilizing now. When
Yep.
before that, it was the quad screen test, alpha fetal protein, but now pretty much, the cell-free DNA is what's largely
Yeah.
used. Although the other tests are still they're called now biochemical tests, are
Mm.
still what are used for detecting spina bifida and some other conditions. So they're still in use. I
Okay.
think what's important, or what we kind of found that was important with our research, is that about, that the majority of people were really getting this cell-free DNA test. But then, I'm going to have to look back at the numbers, but I think it was only 40 to 60% that were getting the amnio at CVS. You have 71% of parents who had a baby with Down syndrome and received a prenatal diagnosis between 2016 and 2021. Of those, 71% said that they got cell-free DNA testing, but then only about 40% went on for a diagnostic test. So a lot of people are stopping at that point when they're
Mhm.
continuing pregnancy.
And tell me what that means. Like, is that problematic in any way? Does that demonstrate that people think of this as conclusive when it's not necessarily? Or does it mean they said, okay, I might be having a baby with Down syndrome and I'm choosing to continue my pregnancy?
I think it's the latter. What's ending up happening is they're like, okay, well, I mean, some people may have a misunderstanding about it, but what we're seeing largely in internet forums where parents are being supported is that they're getting that test. They know that they've got high chances that the baby
Hmm.
has Down syndrome, but they don't want even that slight risk of miscarriage with an
Right.
amnio
Yeah.
CVS. And so they're like, I'm going to stop right here
Yep.
and kind of proceed as if my baby has Down syndrome.
Yeah, and that was actually a different story, but for us, because it was the quad screen that you described earlier, we did have a higher than expected chance for my age of having a baby with Down syndrome, but said no to an amnio because we knew we were not going to change our decision about whether to continue the pregnancy. We were still surprised when Penny was diagnosed because our doctor and technicians and everyone had said there's no way this baby has Down syndrome. That's a different story, but my point just being, I was definitely one of those women who was like, well, I don't need more information if it's going to put my baby's life at risk.
And then there are some people who, maybe because of a past pregnancy loss or, something like that, they want to know for sure because it gives them peace of mind, even for preparation, whether they're, even if they're
Totally.
continuing a pregnancy. So it's just such a complicated, value laden decision. But there are many reasons why people make those different choices. And I think what's important for me, though, is that families need to get information and support after getting screening results. And that's also what the people in our study said, was their preferred time to get information by a large majority, almost 90%. So that's when they want information and not to wait until after diagnostic
I
testing.
see. I see. Okay, that's really helpful. And I think I want to add in here because you've got essentially, and we'll talk about this more in a minute, after a screening result, there a- after a screening result, though, the conversation about termination comes up, right? I mean, that's what comes up immediately with a clinician. Is that correct?
Yeah, I think it does come up at that point, although ACOG recommendations specifically say that, making permanent reproductive decisions should not be done until after diagnostic testing.
Okay. But you've also got an issue. So if you are a pregnant woman who's getting a cell-free DNA test, which is just a blood test, not invasive,
Mhm.
that would be during your first trimester of pregnancy. And then if you get a screening result relatively, soon thereafter that suggests your baby has a high likelihood of one of these genetic conditions, you then would have to wait for a diagnostic test. Is that correct?
I mean, that's the recommendation at this point, but honestly, some of the more restrictive reproductive laws are
Right.
making that more likely that people may be making decisions based on screening because they might not have
Right.
time to get a diagnostic test. And
Right.
that clearly wouldn't be what even ACOG would prefer. They would like for people to know for certain before making those sorts of decisions. But because of the, you know, patchwork that it is that we have right now, people may be making those decisions based on timing as compared to accuracy of the test.
Right. Yeah. So, I mean, again, so many threads we could pull here. I'm not going to pull them all because I want to make sure we get to talk about some of these other things. So, can you just describe the work you've done with the letter case booklet? Is that booklet the right word? Like, I just would love to hear you describe what it is and also talk about whether, yeah, just who is supportive of it, what's been controversial about it, where it gets used, what you've seen happen as a result of it. Just give us, again, kind of a big picture view of Lettercase.
Sure. So we ended up creating these books that were intended for booklets for a prenatal audience, and we submitted it to the Kennedy. At the time, there was a First Call Kennedy Foundation grant, and they reviewed it. And then we ended up submitting it to the Down Syndrome Consensus Group that included representatives of American College of Obstetricians and Gynecologists, National Society of Genetic Counselors, major Down syndrome organizations, and they ended up giving us feedback too. And the idea behind it was that there would be a resource that they could all support and be comfortable with the content, to be provided to families immediately upon receiving a prenatal diagnosis.
And just to kind of be
And
clear there, just sorry to interrupt you, but essentially that's like what might be seen as quote unquote like two sides of the issue. That you have like all the medical professionals who
Mhm.
and all of the kind of Down syndrome advocacy people, and they might be seen to be at odds over some of the choices that women might be given, and yet you're trying to provide a resource that everyone can say, you know, I can support having this in the hands of people right after a screening result comes back.
Absolutely, because I mean, you had at the time a lot of suspicion, between some of those different groups
Yeah.
where, you have families feeling like maybe they didn't have the best diagnosis, and also some concern, yes, about, the possible impact on the population numbers. And then you have on the other side clinicians who are worried about giving non-directive counseling. And so there really were some concerns. So they brought them together at the University of South Carolina for a big meeting in 2008 after ACOG released their guidelines that all women be offered screening, and
Hmm.
tried to work out their differences. And then one of the outcomes of that was we submitted our document to all of them and they gave feedback. And that ended up being controversial once 2011, 2012 hit and the testing actually became available, because at that at that time, one of the compromises that they all agreed to, and I think it's important to kind of point out that we had created the document, but we were not involved in the consensus group at that point. We were just kind of, editors who were
Mhm.
making the changes that they were recommending. And at the time, they said you needed to include all reproductive options. And that was something that was agreed to in that 2010 review after
Okay.
the consensus meeting. But then after there was some pushback, during around, when the testing was released, there was some discomfort from some of the Down syndrome community about the inclusion of the termination language, and
Yeah.
then and so there ended up being some disagreements there. But what's kind of been interesting is that we have continued on with that Down syndrome consensus group and kind of transformed it into a genetic conditions consensus group, because at this point
Mhm.
I am, we ended up donating the copyright to the Kennedy Foundation, and then we now operate at the University of Kentucky's University Center for Excellence in Developmental Disabilities. And so we're
Mhm.
at a university home, and we continued this down or genetic conditions consensus group, and we've since created materials about other conditions: Turner syndrome, Prader-Willi syndrome, Klinefelter syndrome, and we're just finishing up spina bifida, where we bring in representatives from the advocacy organizations. We also make sure to have someone with lived experience as part
Mhm.
of that review team, and then we have the medical organizations, and we've maintained those relationships with ACOG and SGC and ACMG, and that's the American College of Medical Genetics and Genomics,
Thank
in
you.
reviewing all of those materials. So it's still ended up being a collaborative process. And then the interesting thing is in 2017, when we revised our materials, because there are people who often experience loss unrelated to termination because of the higher miscarriage rate, we
Mm.
said, can we as a group address some of these concerns about the termination language by making it a general loss section, and then we can provide, resources that can support people who lose, a pregnancy for whatever reason. And
Mm.
they actually, as a group, agreed to that. But it took working together over many years to develop trust to get to that point.
Wow. Well, and I will say, just for any listener who has not seen this, these materials, which I would assume is most people, the thing that to me stands apart from the information that certainly I received when I was in the hospital, which I did receive. We had a bad diagnosis experience, but then had some nurses who came in and said, "I've got people to put you in touch with," and they had printed out all sorts of information from the internet, but it was just words on paper, a lot of it about what might go wrong in the future. And what I love about the lettercase materials, at least the most recent copy that I've seen, is just there always are photographs. So again, we're not just talking about words, but also images. And there really is a set of, there's medical information as well as social information. And that sense of, not let's put a bow on something that is, for many people when they're first receiving a diagnosis, hard news. Like, let's not pretend that's not going on right here.
Mm.
Let's also give as the language states, an accurate and up to date portrayal of what this might mean, and recognizing that the word might is very operative because, again, each family is different, each child is different, and the prospects are different. So I really appreciate the way in which you have thread that needle, because I think it is pretty tricky. And before we talk about the most recent study, which I promise we really are going to do, I did feel like this one other backstory question is pretty important. So there was a bill passed in 2008 with tremendous support and bipartisan support. And if I understand it correctly, it was meant to make it very clear that those words, accurate and up to date information, should be legally required, that that was how women should receive prenatal diagnoses. Um, and I'd love for you to just tell us the history of that bill. Like, why was it necessary, but also what has changed or not as a result of that bill going through Congress?
Sure. So that bill largely prompted by the research that I mentioned from Dr. Scott Coe in 2005 about the diagnosis experiences that people were having, and it
Yeah.
passed unanimously. But then what ended up happening is but when it was passed, they'd watered down the language, so there was no requirement for the provision of information. But there was supposed to
Uh,
be HHS was supposed to receive funding in order to move forward on those initiatives, and it was supposed to be $5 million a year for 5 years, $25 million to go toward that, and those funds were never appropriated. So I think there was maybe just a small sliver that was done the very first year, amounting to about 300 to 600,000, but they never actually appropriated the funds. And it's kind of baffling in a way, why not, since it passed
right.
unanimously.
Right.
And there still has been, and the need for an educational infrastructure has only grown since it was passed. As far as going back to the photos, I did want to say that that definitely was part of the vision, to give
Mm,
people the opportunity as though they're looking through a window to see what life is like. And we've been really
yes.
careful with the photographs to give broad racial representation, age
Mhm.
representation, and one of the suggestions we got from a very prominent uh, obstetrician was, you need more representation of health diversity. And
Mm,
that was a fair comment. And so we do actually have pictures of kids engaged in therapy and receiving medical care. And
yeah.
I think actually seeing it in the context of looking through a mirror, it's very humanizing, as opposed to some of the old photos. And even now, if
Mhm.
you Google Turner syndrome, you get the black bars over the eyes. And it's a very dehumanizing portrayal of
Mm,
conditions and people.
yeah. Yeah. Thank you for yeah, thank you for telling us that. Well, so all right, let's finally talk about this most recent study, and I'd love for you to say just explain what questions you were asking and why you were asking them, like why it was important to do this, and also what you found as a result.
Sure. So we were there. There have been a number of studies in the past where people have indicated that they had a negative diagnosis experience and that it caused trauma. But we were like, but why? Like, what actually is causing that? So we
Mhm.
looked through the current recommendations, by all of those major medical and genetics organizations, and we constructed, yes, no questions. Did your clinician give you resources about medical issues?
Mhm.
Did they talk to you about social and life outcomes? And we actually asked it both ways, because we wanted to give clinicians credit whether they discussed something or gave resources about something. So we asked these yes no questions, and there was only one of them where the answer was supposed to be, if you're following the recommendations, no. And that is, did your clinician say they were sorry or act like it was bad news?
Okay.
And that ended up being how we divided the groups for implicit bias and not biased, and then compared them, because it ended
So
up
just
being that
backing up for just a minute. If somebody said, if they I, did say I'm sorry or I have bad news, they went into the implicit bias category.
they went into the implicit bias bucket when we were comparing the numbers. Yep.
Yeah. Okay. So sorry, keep going.
No, no, that's a great question. And then we also wanted to get some more context. And so we asked them generally, what was your diagnosis experience like? What resources did you receive? What did your clinician do well? And what could they have done better? So those were the open-ended questions that we also gave.
Mhm. And what were you looking for? Like, why? I mean, you're asking these questions because people have said that they've had traumatic experiences. So, what do you make of the findings?
I mean, we were trying to figure out what kind of information they were getting. And then as we started going through it, and reading their responses, what really started sticking out in the themes was the level of bias that they were experiencing about disability.
Okay.
And so what the findings really told us, so we found out, so the first thing is that 61% said their clinician said they were sorry or acted like it was bad news.
Hmm.
And And then, as we divided up those groups, we saw that the group that said their clinician, the group that qualified as being not biased, right? They performed better in every single category. And that includes, by the way, offering reproductive options, but not by a statistically significant margin in that one. But they performed better in every category and by a statistically significant margin in the provision of more comprehensive prenatal care following a diagnosis, and also in the provision of accurate, up-to-date information, life outcomes, referrals, and information about local and national support organizations. And so we saw that bias was really impacting uh, how these families were being supported and the information that was being provided to them. And that also was manifested in their answers to the open-ended questions. And we started looking for that too. We looked at in these open-ended questions, where also do we see, like, what are the themes among those who describe what would be implicit bias? And also we saw some explicit bias and the difference between those two is implicit is when you just don't realize that you're doing it. Like if you say you're
Right.
sorry as a clinician, usually it's because you're trying to be empathetic, right?
Right. You're trying to have compassion. Yeah.
But then the family often hears, I'm sorry about your baby, not
Mhm.
I'm sorry about your situation. And a lot of times that is the distinct impression that those families described when they gave their open-ended responses. But then explicit bias in those open-ended questions were when they showed clear evidence of discriminatory attitudes that they should be aware are discriminatory attitudes. Um, and so that those were kind of the way that we distinguished between those. And these were evaluated by myself and a bioethicist and also a disability studies scholar. So
Okay, great. Yeah, thank you for all that context. But so, in other words, the majority of people who are offering these results, giving the results of these screening tests, did so with some implicit bias. And but the people who did not exhibit the bias, they gave reproductive options, gave the option of termination, but also gave much more comprehensive, accurate information about having Down syndrome.
absolutely. Yeah. I
Okay.
mean, and you're talking about when you look at when you compare. So there was the question, did your clinician provide you accurate, up-to-date, balanced information about Down syndrome in language you can understand? Only 17% in the implicit bias said that they received that, as compared to
Okay.
51% in the not biased. Now, that being said, that number is still not as high as I know the leaders I work with at these organizations would want it to be,
Sure.
right?
Right, of
Like,
course. Well, and that's my kind of follow-up question is like, I know you've attended conferences and you've been in conversations, working groups, et cetera, with industry representatives, medical practitioners, all these people over the years. Do you think there is institutional resistance, like to presenting an accurate and up-to-date perspective on Down syndrome? Do you think there's um like where is this coming from on the medical side? And you may not have an answer to that, but like, what do you think?
I have a couple of theories. I mean, one, I know that there is just flat out busyness in trying to incorporate all of the learning objectives that they have
Hmm.
for clinicians because, they're struggling just to get them to have the latest information on C-sections, and so
Yeah.
I think there's that element, but I also think we've struggled just institutionally from disability not being seen as an identity and instead
Mm.
being seen as an outcome. And in fact, yesterday was actually people with disabilities were just declared a health disparity population through HHS. Before that, they were not included
Explain. I don't know what
as a
that means. Will
minority
you explain what that means?
underserved population. And so I think that has been it was slowly moving, but then we now have a lot more cultural awareness training that has uh, been a focus for some of these organizations. And then I guess it was 2 years ago, Lisa Iazzoni released her research about the bias that people with disabilities in general experience in healthcare.
Mhm.
And you started to have a real movement in the disability community with National Council on Disability, American Association of Health and Disability, saying, look, we need to be treated as an identity population that can also experience discrimination. And I think that's been now the crack that has opened in order
Mm.
for us to actually make this more of an institutional priority.
Okay, so I'm just this is news to me that I have not like I haven't actually known this before. So disability has been can we go back to that distinction between identity and outcome in the medical world because disability is seen as an outcome that's essentially like a problem to be fixed or avoided? Is that what that would mean?
Yeah. And you've
Yeah.
got, what's called, and so in like disability advocacy world, that's the medical model of disability. We see
Right.
disability as a problem to be fixed.
Yeah.
And in some cases, there are elements of it that are, right?
Right.
Like
Right.
it's very complicated because if my baby with Down syndrome has a heart defect, I want it fixed, right?
Right. Totally.
But there
Totally.
are other things about some of these conditions and, Little People of America, deaf advocates are also very strong in trying to delineate between these are identity issues and these
Yeah.
are or identity outcomes and these are health outcomes. And so
Mm.
that's been a big issue, I think. It's because it's complicated and it's hard for people to understand. It's not as clear cut as something like discrimination for other reasons, because there are certain ways in which we want health issues to be fixed. But then there are
Right.
also other ways that we don't.
Yeah.
We want it to be recognized as identity.
So what you're saying is the government has just recognized disability as an identity for the first time. Is that what I just learned from you?
Yes.
Wow.
I mean,
Okay.
that according to the formal HHS, Health and
Yeah.
Human Services definition, that just happened yesterday.
And I saw that and didn't know what it meant. So now I'm learning so much. Thank you, Stephanie. And I'm sure our listeners are too. So one other question about this identity thing, like how would you distinguish between the social model and the medical model, knowing that sometimes they are connected, to each other?
Yeah, I think, that medical model is, if my child has a heart defect as a person with Down syndrome, we definitely want to fix that. And there's value in that. But
Hmm.
then I also think about one of the best questions I've ever been asked at a conference. And that was, what's a time you were proud of your child for something that had nothing to do with a milestone? And the incident came to my mind almost
Mm.
immediately. And it was when my daughter was in a basketball game and she ended up colliding with another player and she hit her head on the ground really hard.
Mm.
And before anybody could do anything, I see Andy like leap down two benches and he scooped her up and he didn't care about the rules of the game. He didn't care about, I mean, it was just raw compassion for his sister.
Yeah. Yeah.
And I think that that is part of who he is that is included in with having Down syndrome, because he, there are times when he's just very authentic and the rules don't matter to him. And I feel like if
Yeah.
we took away that piece of him, we might lose some of
Yeah.
that, also that raw compassion that he has. And so I think that's where it's really sticky in figuring out that difference between the identity and medical models of disability. And then that social model is, are we giving him all the supports to be as successful as he can be in the world, and all the health, in education, and giving him all the
Right.
opportunities. And that's what he's getting right now with this college experience and some of these other things. But it's a much different world than it was, 100 years ago and 50 years ago in giving people the supports they need to flourish.
Yeah. So different. And also still complicated. And yet I agree. I really do find that I want to be pretty careful in there's it feels like I can't pull Down syndrome out of Penny and still have her. And I want her. So, and she
Right.
wants her. Like, I mean, the world wants her. Like, it's we don't want to lose her, you know?
And that's yeah, they're like Andy's very proud of who he is too, and that's so
Mhm.
important.
I have one more, well, I have two more questions for you. I wanted to ask you just to speak to the role of insurance in all of this. Um, and I assume that's also kind of a dicey question because there's a question of whether insurance companies will pay for these tests, and if so, why, and whether insurance companies want to promote the test, like whether they have an incentive to do that. And so that's my first question is just like, what is the role of insurance? And my second question is, well, no, maybe that's my only question. Will you just speak about insurance for a minute?
Sure. I mean, I guess where I stand with it, I definitely want people to be able to choose the different healthcare options that are important to them
Yeah,
and feel pretty strongly about that. But at the same time, I think that I think that it ends up being kind of an inherently discriminatory if you pay for the screening, but not, and I mean this whether it's the federal government, an insurance company, a state program. If you pay for the screening, but you do not pay for the corresponding educational and training infrastructure, then you're leaving people with
yeah,
information that they don't know how to make sense of. And so and also you're it's not like you're giving them that information in a vacuum. We live in a society that largely has, you know, discriminatory attitudes about people with disabilities that are based on outdated
right,
information. And so you're not giving it to them in a vacuum. And so you
right.
need to be able to provide that that support. And so I mean, in my ideal world, we would correspondingly have training for clinicians on how to discuss disability. Um,
Hmm.
and we would have cultural competency in their curricula for how to do that, as
Yeah.
well as continuing education. We had a big summit in 2022 where we brought together leaders from the medical organizations, genetics, and bioethicists, and advocacy organizations. And these were some of the things they all were agreeing on. You know, we need to be doing those things. We need to have the resources available for clinicians to educate families in that moment. We need to have all of that whole cocoon of support that those families need.
Hmm.
Otherwise, you're just picking up one end of the stick and not the other one.
Yeah, I mean that kind of leads to my final question for you, which is like, what would you want to see in terms of changing the landscape with prenatal testing? And that, what I'm curious about is both the are there legislative efforts? Is it is it? I mean, obviously that training and education is a huge piece of it. Are there any kind of wider social efforts or supports? Is there anything else you would say as
Mhm.
far as like, what do you want to see come out of learning the information you and having the data that you now have from this study?
I would really like to see, and I mean, this is what I mentioned before, but just a much more significant emphasis on training clinicians how to
Yeah.
discuss disability. I think also, those initiatives like the Prenatally and Postnatally Diagnosed Awareness Act, um, the advocates have said that that should be a real priority,
Mhm.
and not to do some of these because I think in a legislative, among policymakers, not to do it for show. And I think that that can happen a lot when you're talking about um, a condition or an issue that can be really politicized, either because of abortion politics or eugenics. And it's really easy to go in those directions. But I think if you have people who really care, a solid focus on disability rights and on patient rights is really is what's going to help the most people.
Mm.
And that's what I would like to see. I would like to see that to be the priority.
Well, I am right there with you, and I really appreciate the faithful work. I almost said tireless, and there's something to that, but I think there's just a faithfulness that you have had in continuing to show up for these conversations and provide the materials and insist on a bit of a middle way within this like fraught landscape when it comes to, as you said, like women actually having choices, but being honored in such a way as to be given real, accurate, up to date information in the face of those choices. And there are people who, whether implicitly or explicitly, would say no to either having the information or having the choices. And it's like, okay, what if we try to honor that place where we provide information and it is accurate and it is up to date, and we also let go of thinking that we're going to control all outcomes, in terms of either what women choose or how life is going to go, when life is brought into this world. So anyway, I just really appreciate your work in this area. I could ask you, questions for a couple more hours, and someday I'm sure I will. But for now, I'm just going to say thank you so much for being with us today.
Oh, thank you so much. And I think you raise a really good point too. I think I'd also say we need to make sure we have those supports in place for people who are living with disabilities so that the world is welcoming in the way that it should be.
Amen to that. I agree. Thank you.